I'm going to talk about target philosophy. I think it's very, very important. Technically, we're all excellent surgeons. The challenge is usually picking the right operation for the right patient. We all know a lot about MIS. I think MIS is certainly here to stay and to grow. If you plot complexity of an operation here at the bottom against invasiveness, you'll see like with open surgery, the invasiveness goes up very, very quickly as the complexity of the surgery increases. With minimally invasive spinal surgery, we're trying to dampen that curve. We're trying to dampen the curve. And I think we've done that very successfully for minimally invasive stenosis surgery, for degenerative spondylolisthesis, for pretty much anything that requires maybe a 3, 4, 5 level fusion. We're really good with MIS. We're not that great yet with complex deformity. And in all honesty, if somebody who had a simple lumbar disc herniation, I cannot with good conscience really say that a minimally invasive operation is so much better than a traditional discectomy. However, that in-between zone is really the benefit zone for minimally invasive spinal surgery. And that's exactly where the indications come in and where the importance come in. How do you pick the right patient for the right operation? We wrote that up. We published that recently. We've put a lot of effort into trying to understand what are the components that make a surgeon successful when it comes to minimally invasive spinal surgery. We mentioned the 6 T's. One is target. Tools and technology is something that we always talk about at all the meetings. We're very, very good when it comes to percutaneous screws, to navigation and so forth. Surgical techniques, very important. That's what you learn during residency and cadaver labs at courses. Teaching and training is obviously important. Research, and then finally talent. I wanted to focus on target because I think really at the end of the day, the most important decision that you make for your patient is really at the very beginning when you decide this is actually a patient for surgery and this is the type of surgery that I think is the safest, the most efficient, and the most successful for that particular patient. And that's the biggest challenge in my experience, also in terms of teaching, training, teaching residents and fellows. So targeted MIS, if you really think about it, it's based on the clinical presentation and the radiology for the most part. You have to understand the clinical problem. A lot of it has to do with understanding what type of pain that patient really has. And I'm focusing here today really on degenerative spinal disorders. I'm not going to talk about cancer, trauma, or infection. This is really more focused on degenerative spinal disorders, where the majority of patients present with various pain syndromes, maybe neurological deficits from nerve compression, but for the most part, really pain syndromes. I'm not really very good at defining particular pain syndrome, and I'll talk about this further. The key is really to correlate symptoms and the radiology to minimize overtreatment and to minimize what we call prophylactic surgery or overtreating surgery. We want to use MIS to the fullest extent, so you want to avoid fusion surgery if possible. Do not treat the MRI scan, obviously. We always talk about this, but in practice, this is very, very difficult. One of the things that I learned early on, I did my fellowship with Volker Sonntag in Phoenix, and he was not really a minimally invasive spine surgeon. We always talk that the least invasive operation is the one that you don't perform because the patient did not need it. So that's the least invasive operation. Always think about that. There's nobody who tells us that we have to operate. Sometimes avoiding an operation is actually the least invasive and actually is the smartest thing to do for your patients and sometimes for yourself. Now look at these films of a patient. This is a patient who came from Italy who had essentially neurogenic claudication, and she came to me a year after having had this operation. It was the most minimally invasive fusion that I've ever seen, tiny little skin incisions. They managed to do a beautiful L4, L5 fusion. They put in cages in, they even did a vertebroplasty. She still had the same symptoms. She essentially had neurogenic claudication from lumbar stenosis. We got an MRI scan. Not only did she have lumbar stenosis still at the level where they did the fusion, but now she's got adjacent segment lumbar stenosis as well. So we ended up doing a tubular decompression and she did really well. And this is exactly the total failure of target. There was no target at all. They saw a degenerated disc and they decided to do a fusion. I think that's really the biggest concern, and that's the biggest trap that we as spine surgeons sometimes fall into. MIS target philosophy: select the right treatment for the right patient, correlate the symptoms and imaging findings, precisely target the pain generator, decompress, stabilize the spinal anatomy as indicated, without over or under treating the patient. It's much easier said than done, but these are the principles of target philosophy. It all starts really with talking to the patient, examining the patient, And the three big categories of pain syndromes that I look at in these patients are, do they have some kind of mechanical back pain? Is it more radicular pain? Or do they have pain or symptoms from nerve root compression, such as myelopathy or cardiac whine, in which case it's obviously an emergency situation. But back pain is very, very difficult to really understand. Back pain can come from so many different underlying pathologies. spondylolisthesis, instability, infection, inflammation, and our ability to really express back pain. We don't have the words really to put really all the different diagnosis into an adequate language. The same is true with radiculopathy. We have radiculopathy from disc herniations pushing on the posterolateral nerve root, on the DRG, which is a totally different type of pain. We always say radiculopathy, but the term radiculopathy actually in itself means very, very little when it comes to trying to make a treatment decision for this patient. So you have to get a really good understanding of what this patient is really complaining about and what the patient's symptoms are. So you have to take a very, very thorough history and examination. You have to look at the imaging, the X-ray, the CT scan, the MRI scan. And sometimes in order to really pinpoint the pain generator and the reason why the pain is in your office, you also have to do testing, like an EMG, nerve root blocks. That's why it's important to work with your partners, such as neurologists, pain management, physiatry, who do these tests and injections to really pinpoint the diagnosis. So the goal here is really to come up with an accurate diagnosis. Once you have the diagnosis, you put it all together to come up with your treatment decision. There are three components of making the right treatment decision. The first one is that you need an accurate diagnosis by correlating the symptoms, imaging, the history, and potentially testing that you've done to pinpoint the pain generator. Then you have to understand the natural history of the disease process. For example, a herniated lumbar disc has a very, very benign natural history. Most disc herniations go away on their own. So the only reason to operate on these is either if it doesn't go away, the patient has a foot drop, for example. But if it's just pain, then the threshold to offer an operation should be very, very high. For degenerative spondylolisthesis, the natural history is also relatively benign, and therefore you can sometimes treat these patients obviously non-operatively or with minimally invasive surgery, and we'll talk about this a little bit further. The beauty of MIS comes in this third component that funnels into the treatment decision, namely the likely impact of surgery on the disease process. And this is really where we as MIS surgeons have a huge advantage, because our impact by definition is minimal. So we're not going to cause instability in these patients. We're not going to cause major disruption of the anatomy, and therefore we can treat disease patterns much less invasively than we used to in the past. Think about those three components when you make your treatment decision. Other factors, obviously, then there are social components and patient expectations and so forth. For the most part, it's really the importance of the diagnosis. You have to understand the natural history of the underlying problem, and then the likely impact of your operation on the disease process down the line. And I'll give you a few examples for that. You have to understand the anatomy. I find this is one of my favorite books really in neurosurgery and spine surgery, where McCullough and Paul Young many years ago beautifully described the principles of the spinal anatomy as it relates to spinal microsurgery in the cervical and in the lumbar spine. It's hard to get, but if you get that book, it's really beautiful. And this is really one of the main struggles that I face, certainly with my patients, is the absence of really language that describes the patient's symptoms. Everybody says my back hurts, and they're going to say they have back pain, they have degenerative disc disease, they have sciatica, a back sprain, bone spurs. We have all these words, but they don't mean anything. They could mean anything. It could be spine related, it could be piriformis syndrome, it could be muscle spasms, it could be hip problems. That's the problem with spine surgery. If you treat aneurysms, if you're a neurosurgeon, you treat with patients with brain aneurysms, they don't have these problems. An oncologist doesn't have these problems. An orthopedic surgeon who treats fractures doesn't have these problems. Only we spine surgeons suffer from this problem that patients are unable to really express their symptoms, and that leads to misunderstandings. I collect books on exploration and science, and this is one of my most treasured books. It's the Tractatus by Ludwig Wittgenstein. And in this book, he really talks about how the absence of clear definitions and poor language really leads to all these philosophical problems that wouldn't even exist if you had the right language to really express what you're trying to say. It sounds a little bit maybe funny, but it's really true. The first requisite of an ideal language would be that there should be one name for every symbol and never the same name for two different symbols. And he goes on to say, the limits of my language mean the limits of my world. And that is so true in the spine world, because if I talk about back pain, it's totally different than a patient's talking about it, or a physical therapist, or a chiropractor. So we don't have the right language to really express what we're dealing with on a daily schedule. Ed Benzel talked about this recently. He calls it pseudo concordance, namely that because of the poor understanding of really what is causing what, you come up with wrong treatment treatment decisions. An apparent but erroneous relationship between an assumed cause, for example, an imaging study, and an effect, for example, back pain. And this pseudo concordance is really what we're suffering from on a daily basis when it comes to spine surgery. And that's why we really try to put more effort into thinking more about target philosophy, trying to figure out what are those different types of pains that we deal with as spine surgeons. There's radicular pain from various types of disc herniations that can cause different type of pain, and there's mechanical back pain, inflammatory pain, and so forth. I'm not going to go through all of them, but I want to summarize just a few of them that are really crucial, I think, in our daily evaluation of patients. Patients who have sciatica, so shooting pain down the leg. It could be a sharp electric shock that's shooting down the leg from a posterolateral disc herniation, like here on the left side, or a lateral recess compression of a nerve. It's very different from a patient who has a foraminal or extraforaminal disc herniation with burning, fire type, sensory dysesthesia type of pain. But these are all radicular pain syndromes. This, again, is very different from somebody who has really bone-on-bone compression because of spondylolisthesis or because of a pars defect, has also radicular pain. In terms of treating that, at the end of the day, it's going to be a totally different treatment algorithm. So we got to really understand these types of pains, and the patient is not going to tell us that. The patient is just going to say they've got leg pain. We as spine surgeons, we have to figure out exactly what type of leg pain, what type of sciatica, where's this pain coming from. So we got to be very, very aware of these different types of pain. Or going further into the DRG, which is really an important structure of us to understand, because the pain from DRG compression, which is in the foramen or just outside the foramen in the lumbar spine, is very different from patients who have pain from a posterolateral disc herniation. The DRG-related pain, because of the presence of sensory fibers and so forth, is more a burning on fire pain, kind of dysesthesias. And sometimes you can really tell from patients who come to the emergency room or your clinic, you can tell from the type of pain that they're describing where the pathology is. Another test that I find very, very helpful in clinic is what we call the Kemp test. And this was originally described to really identify facet joint pain. But if you do it the right way, look at pain that's actually being reproduced by applying this test, reproduced pain shooting down into the leg, you can really diagnose clinically relevant pain from foraminal compression. Like in this particular case, this patient has foraminal compression, leaning backwards and leaning to the side, reproduces that characteristic type of pain. And that's one of the tests that I do in almost every patient to make sure that they don't have foraminal compression, because this requires a fusion. If a patient has this type of picture, you're going to have to do a fusion. A lot of the other pain syndromes, you can do a decompression. That's why this is so important. Neurogenic claudication, obviously very important. We all know this. And mechanical low back pain. Again, I quote Ed Benzel here because he's done a really nice job trying to define it. Mechanical back pain, so unstable spondylolisthesis, for example, pain that is deep, agonizing in nature. It worsens by spinal loading, so getting up from a sitting position, and that is improved by spinal unloading. That is mechanical back pain. And that becomes very important when you're trying to figure out what to do with patients who have unstable degenerative spondylolisthesis, for example. Then obviously these types of patients who have pain everywhere, from those, you should really try to stay away from those patients and not offer surgery. Well, these are the things that we go through in every patient. What type of pain? Radiating, weakness, positional pain. Is it on the right, on the left side? Is it shooting electric pain? Is it burning? Does it static pain? Does the patient have neurogenic claudication, mechanical pain? And then we do some provocative tests in the office to figure out all these things come together. You come up with your diagnosis, and then you go down the decision tree in terms of your surgical treatment, which may or may not be minimally invasive, but obviously, hopefully it is minimally invasive. So what type of pain? What's causing the pain? What's the natural history? And what's the impact of surgery? This was one of the most fascinating cases that I was involved with. This is one of my colleagues, a very prominent spine surgeon. He had multiple back surgeries, and he had essentially L4 radicular pain when he was sitting and no pain when standing. And he asked me to treat him, and I looked at his MRI scan. You can see he had previous laminectomy done here. He's got a little bit of a disc bulge here at L3, L4. He's got overgrown facets, maybe a little bit of a synovial cyst here at L3, 4 on the right side that could cause or causes L4 nerve compression. But then on the parasagittal, he also had significant foraminal narrowing. So I told him, I really think you need a fusion. He said, no, I don't need a fusion. I don't have the pain from the foraminal stenosis. I only have pain from the lateral recess stenosis because I don't have pain when I'm standing. I don't have that diastatic type pain that goes along with the decompression. So he asked me to do just the decompression of the L3, L4 level without doing a fusion. I did that. That was probably 5 or 6 years ago, and he's been doing really, really well. And that was, for me, was really a turning point because suddenly I had a spine surgeon who was actually the patient And he really made me understand how you can, if you're really sensible, you can understand what's causing the pain, what needs to be treated, and what doesn't have to be treated. So that was a very telling experience for me. This is an example that I like to show. This is a patient with degenerative spondylolisthesis, L4-5. This case could go either way. This case may need a fusion, may need a decompression. It all depends on the clinical symptoms and some radiographic parameters. So this patient has grade 1 spondylolisthesis. This particular patient had neurogenic claudication. And if you do a tubular decompression in this patient, and this patient doesn't have mechanical back pain, you can treat these patients very successfully without having to do a fusion. And that's really based on the fact that you as a surgeon examine this patient very carefully, and you understand that they do not have mechanical back pain, but they have neurogenic claudication. You know that based on your decision making, you know that the natural history of degenerative spondylolisthesis overall is very benign. You have an accurate diagnosis. It's neurogenic claudication. It's not mechanical back pain. And the likely impact of a tubular decompression is minimal. You don't really destabilize a patient by doing a tubular decompression. So this leads you down the treatment of a tubular decompression without having to do a fusion. Now, the same patient, if that patient had mechanical back pain, I would do a fusion. But this patient didn't have a mechanical back pain. We did a decompression without a fusion. You can look at radiographic parameters, at the facet joints, at the disc space. How likely is that patient to, over time, deteriorate? Algorithms that have been described. My point here is that a lot of it is really the clinical history. So it's neurogenic claudication, central stenosis is causing the pain, no instability clinically on flexion extension films. So we did a tubular decompression, and this patient did really well. This patient actually had mechanical back pain, but also neurogenic claudication. And this patient had a bunch of imaging studies. You can see degenerative spondylolisthesis at L4-5. Now this patient had lumbar spinal stenosis not only at L4-5, but also at L3-4. So now the question is, based on the mechanical back pain, you probably want to do a fusion. To treat the mechanical back pain, you have to do a fusion really at both levels. At L3-4, there's no spondylolisthesis, there are no signs of instability. So with minimally invasive surgery, what I frequently do is I may do a fusion at one level where there's clear instability, and the level above or below, I'll do a tubular decompression and call that a 1.5 procedure, because you do a fusion at one level and just a decompression at the other. Question is, what about indirect decompression, a lateral approach? You could certainly technically do that. The anatomy may not be great here in terms of the psoas anatomy. I would still not be comfortable relying on indirect decompression because his symptoms are, again, so significant for neurogenic claudication. I decided to do an MIS TLIF here in this case with a tubular decompression at the level above. That's what we call the 1.5 TLIF lateral case. Now, this is a patient with degenerative scoliosis who presented with leg pain. No mechanical pain from the degenerative scoliosis. We got imaging studies. That's a perfect indication for what we call the chem test. You have the patient lean backwards to the side where the pain is, and that movement compresses the nerve root in the foramen and reproduces the pain going down the leg. That confirms the diagnosis. So the goal is to decompress that nerve, in this case, the L3 nerve that was trapped between the L3 and L4 pedicles. And we did that with a lateral approach. This was done a while back. The diagnosis is important. We did all the testing. We went through the algorithm, did a lateral approach, put in a lateral cage, and that's the beauty of the indirect decompression that you can achieve with a cage. In this case, we put in a lateral plate. I don't use lateral plates anymore. Nowadays, I would put in percutaneous screws in a single stage operation. This was now 15 months post-op, and you can see both foramen on both sides are beautifully decompressed. This patient did really well. There was no need really to address the overall deformity from the scoliosis, because the patient was elderly and was not symptomatic from the scoliosis. So again, that's the power of minimally invasive spinal surgery. This is a patient with similar situation with leg pain when standing, severe foraminal compression here at L4-5, spondylolisthesis. She had multiple decompressions done in the past, has shooting pain down the leg when she's standing for longer time periods. We evaluated her, we did that chem test that reproduced the radicular pain that she had. In terms of lumbar stenosis, because she had previous decompressions done, she did not have very significant central stenosis, maybe some lateral recess stenosis here. How did we decide to treat that? We decided to do a lateral approach for indirect decompression here, and we did that in a single stage fashion with a lateral approach, and then put in screws from the side in a single stage with navigation. We just published the single stage Viper Prime pedicle screw system, which works beautifully for these types of operations, and this patient probably went home the next day and did really well. In my opinion, the most important thing is really to to define your surgical target, especially with MIS, because we have limited ability really to treat pathology because of the nature of what MIS really means. And therefore, it is so much more important to come up with the correct diagnosis. But if you do it correctly, you can do it very successfully, and these patients are going to do really, really well.